Once again, thank you for joining us and welcome. So I am your host, Adail, and with me I have Dr. Khalib as my co-host. Dr. Abil from ESIM has joined us as well, and our guest speaker, Dr. Ephrem Fantu. So before proceeding with our webinar, I would like to say a few introductory remarks about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. Currently has more than 70 active volunteer members, spanning across 5 different countries, counting more as well. So our projects and engagements could be divided into four major aspects. So the first is health promotion. So it's mainly concerned with discussion and also uh, articles that are concerned with the health of the general public, with health policy and its implementation. Our another engagement is our community engagement through blood drive, inclusivity trainings, equity projects, fundraising campaigns. Our third project is the mentorship and skill sharing. So it provides direct mentorship, soft skill, career and professional development webinars to healthcare professionals. And our last is our medical education project, which under it has the CME and research and UI projects. So it now is more than a digital platform. It provides a platform where its volunteers can come together in person and volunteer across various of our aforementioned projects and engagements. So as you can see from this picture, we have our volunteer members participating in blood drive donations, in inclusivity trainings, and in donation campaigns. So this is also another several image showing our members participating in our several activities. So Yetena also collaborates with Roha and IMSA for its health article writing competition. So the third round of health article writing competition was organized in collaboration with IMSA. So Roha Medical Campus will award travel grants for 2 health article writing competition winners. Yetena will award pulse oximeters for the top 20 winners and Littman stethoscope for the top 3 winners. The top 5 winners will also get internship opportunities at Roha Health and other partner institutions. So the image on the left is showing the 2021 winner receiving her award, and uh, on the right is a picture showcasing our prize that was prepared for the 2022 winners. And on this slide, we have 2 of our winners from the 2023 article writing competition that got the opportunity to travel abroad and participate at the University of Global Health, Kuwaiti campus. It now also collaborates with Roha for its research fellowship. So Yetena Weg with Roha Research Fellowship with Addis Ababa University Medical Faculty was organized. It started on March 14th. 3 departments were mainly involved: oncology, radiology, and internal medicine. Research grant were awarded for the top 4 winners, and mentorship was awarded for the top 10 winners. Yetena Weg also collaborated with Roha for its St. Paul Hospital Medical College wing. So it was prepared for medical students instead of residents. Research grant was awarded for 4 winners. The winners have already been announced. This is a slide showcasing the winners of the research fellowship from Black Lion. So as you can see, there are 2 residents from internal medicine, another resident from oncology, and another resident from radiology. And these are the winners from the St. Paul wing. So coming to one of our projects, which is CME. As you can see, this is a slide showcasing our several CMEs we've had throughout the years. Our CMEs are freely accessible. So for this, Yetena Weg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We've had 11 CME webinars held so far. Our average webinar attendee has varied from 150 to 200 healthcare professionals. For the year 2024, we've planned more than 30 webinars focusing on emergency and surgical medical cases, ANT, pediatrics, OBGYN, and oncology cases. We invite renowned local and international speakers. So you can access our previous CME sessions through our YouTube dedicated channel. And you can also get updates about our upcoming CMEs by joining our Yetena Weg's Telegram channel for healthcare professionals, or by following various of our social media posts. We'll provide the links shortly below. So for the best for the best experience in the webinar, send your questions on the Q&A or on the chat box. And at the end of the webinar, the questions will be addressed by the guest speaker accordingly. And to get CU certificates, attendees must fulfill the following set of criteria. The first is attend the whole session virtually. The minutes attended will be checked by Zoom attendee reports. So you must be able to fill in the Google form for personal details and attendance. So the personal details you provide should be accurate, and you should be able to score 50% and above on the post-webinar quiz. So provided that you've been able to fulfill the following prerequisites, you'll get your results right away, but the certificate will take 1 up to 2 weeks to be delivered to your email. So we ask that you wait patiently in the meantime. So this is all about Yetena Weg. Thank you. So we're joined by Dr. Abel Muraja, the CPD Director of ESIM. So Dr. Abel will say a few introductory remarks about ESIM.
Okay, thank you so much. Thank you, Tadael. Welcome and good evening, everyone. I just want to say a couple of points about Ethiopian Society of Internal Medicine. Ethiopian Society of Internal Medicine is a professional society that was established more than 11 years ago, and it has more than 1,000 members and more than 1,500 associate members and 18 chapter offices. It was established with a mission of improving the quality of healthcare by fostering clinical excellence, medical professionalism in the field of internal medicine, and also we want to be recognized as a leader in promoting quality clinical care, advocacy, education, and research in internal medicine and its subspecialties in Ethiopia and beyond. As part of our mission, we prepare regular educational sessions and update lectures on topics that fall under the umbrella of internal medicine. And as part of that, today we have collaborated with Yetena Weg to bring you this session on updates on management of acute exacerbation of bronchial asthma and COPD. We're grateful for this collaboration and also thankful for Dr. Ephrem Fantu. And we appreciate everyone attending, and we hope we'll have a good educational session. Thank you very much.
Thank you very much, Dr. Abel. So I'd like to say a few things about Dr. Ephrem Fantu, our guest speaker for today. Dr. Ephrem Fantu is an accomplished physician who specializes in pulmonary and critical care medicine. His medical career began with his Doctor of Medicine degree from Arba Minch University, followed by residency training in internal medicine at the University of Gondar. He then completed a fellowship in pulmonary and critical care medicine at Addis Ababa University and the East African Training Initiative. He currently holds the position of Assistant Professor of Medicine at the Kurambisa Specialized Hospital. In addition to his clinical work, Dr. Ephrem is an active researcher and has published several papers in peer-reviewed journals. He is a member of various professional associations, including the Ethiopian Medical Association, Ethiopian Society of Internal Medicine, the American Thoracic Society, the European Respiratory Society, the Pan-African Thoracic Society, and the Ethiopian Thoracic Society, where he currently serves as an executive member. So with that said, I would like to welcome Dr. Ephrem. Thank you, and please proceed.
Thank you, everyone, for joining us for this session. I'm so happy to be here to share what I have with you. So this session will be on management of asthma and COPD. So we will start with some introduction on asthma and COPD. And we will talk, in short, we will discuss on etiologies and the triggers of asthma and the COPD exacerbation. And then we will focus on management of exacerbation of asthma and COPD. And mainly we will focus on more severe and life-threatening exacerbations. Okay, let us start with asthma exacerbation. As you know, from the definition, asthma exacerbation is an episode of increased worsening of respiratory symptoms plus change in baseline lung function. So usually these patients have respiratory symptoms, I mean worsening of respiratory symptoms, cough, shortness of breath, chest tightness, and in addition to that, they will have change in baseline lung function. So usually the patients may not have the symptoms which correlate with the baseline lung function. Sometimes the patients may have mild symptoms, but they may have a significant change in baseline lung function. So we shouldn't ignore patients with mild symptoms also. It's changing patients with changing symptom with mild changing symptoms because they may have significant change in their baseline lung function. So since we don't know that, we shouldn't ignore patients with mild symptoms also. So when we see triggers of asthma exacerbation, commonly, the triggers are respiratory infections. Most commonly, viral respiratory tract infections are the most common triggers of asthma exacerbation. So this is important because we should understand this when we consider antibiotics for patients with asthma exacerbation. So whenever we consider antibiotics, we should have clear evidence of bacterial infection because we know viral infection is the most common trigger. And in addition to that, other triggers are allergens, you know, this tobacco smoke, chemical irritants, seasonal change, cold air, exercise, and others can cause or can trigger asthma exacerbation. But the most common one is viral infection. From the viral infection also, these are some of the common viruses associated with asthma exacerbation. The commonest one is the rhinovirus, but during the COVID era, COVID coronavirus is also one of the common cause of asthma exacerbation. So whenever we consider antibiotics in these patients, we should consider bacterial, triggering agents. So usually viral infection is the most common one. In addition to that, non-infectious causes are more common causes of triggers of asthma exacerbation. When we come to the clinical features, usually the patients will have worsening of their respiratory symptoms, and these symptoms depend on severity of exacerbation. So the common symptoms are, as you know, dyspnea and increased cough. These are the common symptoms, and the change in vital signs like tachypnea, tachycardia, hypoxemia, decreased saturation, pulses paradoxus can be seen in some patients based on the severity of the exacerbation. In addition to that, on physical examination, we may see expiratory wheeze, prolonged expiration, hyperresonance on percussion, increased work of breath, silent chest, especially in patients with severe life-threatening exacerbation, change in mental status. These are some of the clinical features commonly we can see. The diagnosis is usually clinical. So as I mentioned, they will have change in symptoms and they will have change in baseline lung function. So we should consider these two things, change in symptoms and change in lung function. If possible, we can check change in lung function, but if that is not possible, we can diagnose based on the signs and the symptoms of the patient. So we shouldn't delay the diagnosis or starting of the treatment while waiting for the diagnostic workup. But if available, we should check pulmonary function test. Specifically, we can check with peak flow meter. So this is very important for objective measurement. So if a patient is not in life-threatening exacerbation, we can try this in patients with mild, moderate, or even with severe exacerbation. We can try with peak flow meter if available. So the decrement of peak flow meter from the baseline or from the predicted, if it is less than 80%, that is one of the indicator of asthma exacerbation. So if possible, we should check this one. This is important because before starting the treatment, if we check this after starting the treatment, we can see the response of treatment with this measurement. So if we find peak expiratory flow less than 50%, that is one of the indicator of severe exacerbation. The other workup, what we can do is arterial blood gas analysis. So this can be done in patients who cannot do peak flow measurement, or if the peak flow measurement is not available, we can consider this one, especially in patients with severe or life-threatening exacerbation, or in patients with clinical worsening or patients with poor response to the initial treatment. And in patients with also symptoms of hypercapnia, we should check arterial blood gas analysis. So the findings, if we do arterial blood gas analysis, what can we find is initially we see respiratory alkalosis, because these patients are usually initially they are hyperventilating during the initial attack, so that they are hyperventilating, so they are losing or they are expelling much carbon dioxide, so that they will have respiratory alkalosis, so that the PCO2 will be lower, the pH will be higher. But over time, when the symptoms are worsening, the patient gradually, the respiratory effort will be fatigue, and the patient's breathing or hyperventilation will be decreasing, so that the respiratory acidosis starts to develop because of the retention of carbon dioxide. And concomitantly, the patients will have severe hypoxemia, and the pH will be decreasing or normalizing, because initially the pH is usually above the normal, because the patients are hyperventilating, they will have higher pH. But after if the treatment is delayed, and if you check the ABG after that, the patients will have increased carbon dioxide or increased PCO2 with decreasing or normalizing pH level. And the other is they will have severe hypoxemia. So these are the findings we can see if we can do arterial blood gas analysis in asthma exacerbation. Chest X-ray is not mandatory, but if you are considering other alternative diagnosis, we should consider chest X-ray. You know, the findings, mainly the findings are pulmonary hyperinflation, bronchial thickening, usually due to chronic inflammation. So after doing this, we should classify the patients. This is important for managing the patients. So we should classify as mild or moderate, severe, or life-threatening asthma based on the peak flow measurement, and based on the symptoms of the patient, and based on the other vital sign parameters. So I think you know this. So based on this, we should classify the patients into three. This is important for management. After classifying, if the patients have mild or moderate exacerbation, we should start treatment with inhaled beta agonists. They are the first line treatments, and we may consider and we should consider glucocorticoid. Systemic glucocorticoid should be given. So after treating, we will see the detail of this treatment. After treating with inhaled beta agonist and with glucocorticoid, if the patients have if they don't have adequate improvement, we should include them into severe exacerbation management. So in severe exacerbation management, the options or the treatment options are we should urgently give respiratory support for these patients, and we should give beta agonists, I mean short-acting beta agonists, and short-acting anticholinergic agents should be also added for these patients, for patients with severe and life-threatening exacerbation. Systemic corticosteroid and IV magnesium can be considered. So regarding the oxygen supplement, our target of oxygen supplement is 92% or above that, but in pregnancies it should be higher, like more than 95%. So targeting this oxygen level or targeting this saturation, we should give oxygen supplement for these patients. So we can give oxygen with nasal cannula, we can give with face mask based on the saturation or based on the hypoxia of the patient. But usually these patients do not require much oxygen. So with minimal amount of oxygen, usually they are expected to improve with the proper treatment. So if they are not improving with adequate oxygen and with proper management, we should consider other alternative diagnosis. The other important treatment is bronchodilators. So bronchodilators, we have initially we should use short-acting agents, so short-acting beta agonist and short-acting anticholinergic agents should be considered in patients with severe or life-threatening asthma exacerbation. So in short-acting beta agonist, albuterol can be started initially. So these patients are in severe exacerbation or in life-threatening exacerbation. So these patients may not properly take these medications. So we should give, if available and if possible, we should give by nebulization. So we should give albuterol 2.5 milligram every 20 minutes for 3 doses. And after that, we proceed based on the response for the initial treatment. But if the nebulizer is not available, we can consider a meter dose inhaler, but that should be with a spacer. That should be with a spacer. So we should give the same amount of treatment. For puff means it is around 2.5 milligram. So we should give this dose every 20 minutes. Again, then we proceed based on the response. So the other is if the patients are having severe exacerbation with life-threatening exacerbation, we may consider also giving continuous nebulization over 1 hour can be also considered. That is also another option. The other is ipratropium bromide short-acting anticholinergic agent is another option. So this should be added for patients with severe exacerbation or patients with life-threatening exacerbation on top of the short-acting beta agonist. So when we give, we should give, if possible, we should give with nebulizer. If that is not possible, we can give the meter dose with spacer. So we have different options of spacers. So if the patient is cooperative and can take this type of spacer, we can give this one. But if the patient is not cooperative, we can use the spacer with a mask. So these are the options of giving bronchodilators. The other treatment is systemic glucocorticoid. So this should be also considered for all patients with asthma exacerbation, and this should be given within 1 hour of presentation to the hospital. Because the onset of action of glucocorticoid is around 4 to 6 hours, so we should start early to see the effect of the drug. So it should be started within 1 hour, and giving this drug considered to decrease the admission rate, because the importance of this drug is it decreases the inflammation and the inflammatory mediators, and also it helps the effect of the other bronchodilators, the beta agonists. It increases the expression of the beta adrenergic receptors, so that it is one of important part of treatment for acute exacerbation of asthma. And the route of giving this drug is we can use IV or oral route. So both are effective, or the effect is similar. So if the patient can take PO, we can give PO. So these patients are usually, especially patients with life-threatening asthma, they may not take oral. In that case, we can consider IV. Otherwise, we can give IV or oral, or initially we can start IV and we can change to PO when the patient can take PO. So both routes can be used. So we can use prednisolone or IV hydrocortisone with equivalent dose of 40 to 60 milligrams. So this dose should be given for about 5 to 7 days. That also decreases the relapse rate. But the other thing is adding inhalational corticosteroid for this patient is not useful. But if the patient was initially taking inhalational corticosteroid, or if the patient was initially taking drugs like Symbicort, which is a combination of inhalational corticosteroid and the long-acting beta agonist, they can continue their long-acting agents when they can take the drugs. Otherwise, adding another inhalational corticosteroid on top of systemic corticosteroid is not beneficial. So after giving this treatment, we should check for response if the patient is responding or not. So if the patient has good response, if the symptoms are resolved, or if we can do peak flow meter, if the peak expiratory flow is greater than 80%, we can consider discharge of the patient with adequate education and who is advised to take his drugs every 4 to 6 hours and starting the inhalational corticosteroid and continuing the systemic steroid for 5 to 7 days. But if the patient has inadequate response, we can keep the patient and we can continue the treatment for 1 to 3 hours and then should be decided based on the response. But if the patient is worsening, if the symptoms are worsening, and if the peak expiratory flow is worsening, we should consider admitting this patient, and we should consider consulting the ICU team also for early preparation for the treatment of this patient. So during this time, we should continue the bronchodilator therapy. We should titrate the amount of oxygen giving to the target of 93 to 95% saturation. And we should also consider additionally magnesium sulfate. And also we should rule out or we should check for other alternate diagnosis. So if the patient is having respiratory failure initially, or if the patient is having impending respiratory failure, we should be ready for the ventilatory support also. So regarding the magnesium sulfate, this is also one area of controversy in asthma management. So most of the evidences come from this systematic review, which was done in 14 studies, including more than 2,000 participants. So based on this study, using magnesium sulfate in patients who are not responding for the initial treatment, for the treatment in the first 1 hour, for those patients not responding, if we give magnesium sulfate of 2 gram IV, they have improvement, or there will be decreased hospitalization rate with use of this magnesium sulfate. So the effect is related with the bronchodilator activity, probably by inhibition of the calcium influx into the smooth muscle cells. So that based on this study, most of the current guidelines recommend using magnesium sulfate as additional therapy for patients who are not responding for the initial 1 hour therapy. That means patient is not responding for short-acting beta agonists, short-acting anticholinergic agent, and systemic glucocorticoid. If the patient is not responding for this, additionally, we should consider 2 gram of magnesium sulfate, but it should be only single dose. Single dose of magnesium sulfate should be considered. And the other is ventilatory support for patients with asthma exacerbation. So when we consider ventilatory support, we have different options. We may consider non-invasive and invasive ventilatory support. So non-invasive is, as you know, it is well studied in patients with COPD exacerbation, but this is not well studied for asthma. But if the patient can tolerate non-invasive ventilation, if the patient does not have any contraindication for non-invasive ventilation, like if the patient is not having significant secretion, if the patient has significantly impaired mentation, in that case, the patient may not tolerate non-invasive ventilation. But if the patient does not have contraindication for non-invasive ventilation, we can consider initially with non-invasive ventilation, and we can see the response. If the patient is not responding with non-invasive, specifically the non-invasive with BiPAP, if the patient is not responding with this treatment, we should early consider intubating this type of patients. So regarding the intubation and the mechanical ventilation, this is also one of difficult part of management in patients with asthma exacerbation. As you know, mechanical ventilator
Excuse me,
is
doctor.
life-saving, very important modality of treatment. Okay, so mechanical ventilation is very important part of management, but as you know, it will have many complications, and it is associated with many morbidities and mortalities. So specifically in asthma patients, if you intubate the patient, the bronchoconstriction may be worsened, and that will make the treatment much difficult. So we should consider the risk and the benefit before considering the mechanical ventilator. But if possible, we should try to avoid mechanical ventilation. If possible, if the patient can tolerate and if there is no contraindication, we should consider, we can consider non-invasive ventilation. So if the patient is having cardiac or respiratory arrest, or if the patient is having imminent respiratory arrest with worsening hypoxia, worsening hypercapnia, respiratory acidosis, change in mentation, in those conditions, we can consider invasive ventilation. So during intubation of this patient, we can use rapid sequence intubation, and we should use larger size ET tube, like greater than or equal to 8 millimeter. That will be important, minimizing the resistance and enabling suctioning properly. But if that is difficult, using larger ET tube is difficult, we can start with a smaller ET tube, and after that, after stabilizing the patient, we can change the ET tube. That is also another option. Regarding the induction agent, we can use ketamine or propofol. They have also bronchodilator properties, so they can be used during the intubation process. But ketamine is because of its additional benefits like hemodynamic support. Ketamine is most of the time preferred during intubation of these patients. Regarding the neuromuscular blocking agents, it is similar to other general population, so they can, the drugs like succinylcholine and others can be used based on the clinical condition of the patient. So there is nothing special for asthma patients regarding the neuromuscular blocking agents. So before starting the intubation, the patient they should take bronchodilators. That will also help decreasing the bronchospasm associated with the intubation procedure. So after intubation of these patients, managing the mechanical ventilator is also another difficult issue. So regarding the mode of ventilation, it is also not well studied. Different clinicians use different modes. So most commonly used modes are the volume limited or pressure limited modes are commonly used, but the most common one is the volume limited or volume control mode is commonly used, because this mode is very important to limit the minute ventilation we are giving for the patient. So commonly used mode is the volume controlled mode. And on machine setting, we should make the rate lower, like 8 to 12 breaths per minute. And the tidal volume should be like 6 to 8 ml per kg of ideal body weight. Minute ventilation to be 8 to 10 liter per minute. And IE ratio, inspiratory to expiratory time ratio should be also, especially the expiratory time should be longer. So we can use 1:3 or 1:4 ratio, even it can be used up to 1:5 ratio can be used, because the expiratory time should be longer in this patient to decrease the risk of air trapping. The other is plateau pressure should be less than 30. Peak should be started with lower, like 5, and it can be increased up to 8. And we can start with FiO2 oxygen of 60%, and after that, we can titrate based on the saturation of the patient. And after intubation, we should follow the patient. We should closely follow the settings to maintain adequate oxygenation and to prevent high airway pressure. So there are so many complications which can occur, specifically in patients with asthma. So we should closely follow some of the parameters, and we should adjust based on the findings. So one of the common problem is dynamic hyperinflation in these patients. So usually the patients after intubation, they are trapping the air. That means they are not expelling all of the air that entered into the lung. So they are gradually building air inside the lung. So they will have progressive dynamic hyperinflation that is leading to increment in the plateau pressure and creating also autopy. So that is very common condition in patients with asthma, as well as other patients with obstructive lung disease. So this leads the presence of dynamic hyperinflation commonly leads to cardiovascular collapse because of decreased venous return. That may lead to barotrauma, and that will lead to also increased work of breathing while the patient is on the mechanical ventilator. So to see one of the effect of, the common condition in patients with asthma, exacerbation on mechanical ventilator. So autopy is one of the common condition. So here you can see the respiratory limb, and here you can see the dot lines. This is the normal expiratory limb. So you can see this on the screen of the mechanical ventilator when you follow the patient on mechanical ventilator. So when you check the flow time curve, on the flow time curve, you see the inspiration is normal, but when you come to the expiratory limb, it is not coming directly to the baseline. It is not coming to the directly to the baseline. So there is air trapping here. So before reaching to the baseline, the inspiratory limb starts. So this is one of indicator of air trapping or autopy in patients with obstructive, commonly we see in obstructive airway disease. So to adjust this problem or to avoid this problem, we should follow the ventilator parameters. And what we should make is we should decrease the respiratory rate, and we should decrease, we should increase the expiratory time by decreasing the flow rate. By increasing flow rate, and we should increase the expiratory time, and we should decrease the respiratory rate, and we should decrease the tidal volume on the ventilator. That will help to decrease the autopy as well as dynamic hyperinflation. So the problem with decreasing the respiratory rate and decreasing the tidal volume is usually that leads to the hypercapnia. So the patient will have hypercapnia due to the decreased respiratory rate, decreased tidal volume. So the hypercapnia should be tolerated as much as possible. So usually the patients with chronic respiratory, especially obstructive respiratory problem, they can tolerate the hypercapnia. So we should tolerate the hypercapnia that we call permissive hypercapnia. So if possible, we should check the EVG, and if the pH is not less than 7.15, that is acceptable. If it is greater than 7.115, that is acceptable with a high level of PCO2. So this is common problem. So patients with asthma exacerbation on mechanical ventilator, commonly we can find autopy. So we should check, usually you can check the flow time curve, and you can easily find the presence of autopy, and we can adjust by decreasing the tidal volume and the respiratory rate. Okay, the other is failure to respond to the treatment. So patients who are not responding to the initial treatment for the bronchodilators, systemic glucocorticoid, magnesium sulfate, and ventilatory support. So if the patient is not responding, we should consider other possible other causes or other diagnoses. So viral infections, others like bronchiectasis with allergic bronchopulmonary aspergillosis. So especially patients with bronchiectasis, patients with uncontrolled asthma with bronchiectasis, they may have possibility of having this allergic bronchopulmonary aspergillosis. We should consider that. And also we should check or we should consider gastroesophageal reflux disease, cardiac problem, pulmonary embolism. So other possible diagnoses should be seen, because we expect the patients to respond as much as possible within 48 hours. They should have significant response. If the patient is not responding, we should consider other possible diagnoses. But if there is no possible diagnosis, and if the patient have no additional comorbidity, and if the patient is not deteriorating on the treatment being given, we can continue the treatment and we can wait the patient for the improvement even after the 48 hours. But if the patient is persistently not improving or worsening, additionally, we can consider other treatment options, which are known as non-standard therapies. So these non-standard therapies are treatments which are considered without having significant or strong evidence. So they have effect, but their effect is not strongly evidence-based. So the use of anesthetic agents like ketamine, use of helium with oxygen mixture, use of ECMO, parenteral beta agonists like epinephrine parenteral and parenteral parenteral terbutaline are some of the drugs suggested. But these are not based on the strong evidence, but in the absence of improvement, these are the options which can be considered, but they are not recommended for use routinely. The other ineffective therapies in asthma are leukotriene receptor antagonists. They are not recommended for treatment of asthma. They are not effective. Maybe they are effective in treatment of asthma exacerbated by aspirin or other non-steroidal anti-inflammatory agents. Otherwise, they are not effective agent for asthma management, asthma exacerbation management. The other is IV methylxanthines are also not effective for the treatment of asthma because they have bronchodilator effect, but their effect is not better than that of the beta agonists or short-acting beta agonists. But these drugs have significant side effects, so they are not recommended to use on top of beta agonists. And other treatments which are not effective are hydration or giving fluid for the patients with asthma exacerbation. We should check their hydration status. If necessary, fluid can be given, but it is not routinely recommended for all patients. The other is use of antihistamines, just physiotherapy. These are non-effective therapies which are practiced sometimes. The other important issue is use of empiric antibiotics. So antibiotics is not routinely recommended in patients with asthma exacerbation. As we have discussed, most of the time, the exacerbation is or the triggers are viral infections most of the time. So unless we have significant evidence for bacterial infection, there is no need of giving antibiotics for patients with asthma exacerbation, even those patients who are hospitalized. The other issue is asthma management during pregnancy. So as you know, in pregnancy, asthma could be worsened in 1/3 of patients, and in another 1/3, it is not affected, and in another 1/3, they have improvement also. So Exacerbation usually seen in these patients in second trimester, most of the time associated with the hormonal changes and other anatomic changes in these patients. So the treatment is not different from treating other patients. So they can take short-acting beta agonists, oxygen, glucocorticoids, magnesium, and other treatments can be given for patients with asthma. So they should be treated with as other patients with asthma exacerbation. But those patients who are taking high amount of short-acting beta agonists during delivery or during labor, the neonates should be followed for neonatal hypoglycemia because of the short-acting beta agonists. They may have a risk of developing hypoglycemia. The other is prevention of asthma exacerbation in patients, in pregnant patients. So usually these patients discontinue their medication or the drugs are usually de-escalated. So we shouldn't de-escalate or we shouldn't stop any medication which is given for asthma management in patients with pregnancy. So they should take their drugs, their maintenance medications. We shouldn't de-escalate or stop these drugs. Okay, this is about asthma. So let us see about COPD worsening or COPD exacerbation. So COPD exacerbation, when we define it, it is a worsening of the symptoms of respiratory symptoms, specifically the cardinal symptoms, the worsening of cough, shortness of breath, and sputum or sputum increment or changing color of sputum. So this usually negatively affects the life of the patient, quality of life of the patients, and usually it accelerates the decline of the lung function in these patients. So it is also usually associated with significant mortality in patients with COPD. So especially patients requiring hospitalization due to the acute exacerbations, they have increased risk of mortality. Considering the causes or triggers, most of the causes are respiratory tract infections. Again, the viruses are the most common causes of respiratory, most common causes of COPD exacerbation. Rhinovirus is as that of asthma. Rhinovirus is the most common one. And in the remaining 20 to 30% of cases, other causes like eosinophilic inflammation, environmental pollution, non-adherence, and other unknown causes are associated with the exacerbation. So respiratory infection is the most common cause of exacerbation, and still viral is more common, but in the case of COPD, bacterial infection is also more common when we compare with asthma exacerbation. So major risk factors for exacerbation are previous exacerbation and advanced COPD are the most common causes or risk factors for exacerbation. When we see clinical manifestations, there are cardinal symptoms, worsening of dyspnea, increased frequency and the severity of cough, increased volume and the purulence of sputum. These are the cardinal symptoms of COPD exacerbation, and the patients may have other additional symptoms. When we come to the diagnosis, or again, it is based on the clinical manifestation, changing the symptoms of the patient and the presence of the cardinal symptoms over the past 14 days or over the past 2 weeks. It can be accompanied by other concomitant systemic or local symptoms. And additionally, we should rule out other possibilities or other diagnoses because these COPD patients have, most of the time they have comorbidities. So we should also exclude the worsening of other comorbidities. So in short, the diagnosis is based on the clinical manifestation of the patient. It is mainly clinical. So after diagnosis, we should check the saturation. We should check the ABG for patients with severe exacerbation, and we should classify the patient's severity based on the clinical manifestation, based on the dyspnea of the patient, based on the visual analog scale, based on the vital signs, and other C-reactive protein, and others like ABG results, we can classify the patients into mild, moderate, and the severe classes. So in the case of severe, most of the time they have respiratory acidosis, but in other moderate and mild cases, they don't have respiratory acidosis. When we come to the management, majority of the patients can be managed as outpatient, those patients with COPD exacerbation. So after initial office visit or after initial emergency visit, they can be discharged after initial treatment and they can be managed as outpatient. So when we see the treatment options, we should give supplemental oxygen if necessary. We should give bronchodilators, the beta agonist and the other short-acting bronchodilators. And we should give corticosteroids for these patients. And we can consider antibiotics for these patients. Our threshold for using antibiotics in these patients is very low in patients with COPD exacerbation. We will see that in detail. And we may consider ventilator support for these patients also. So when we see the bronchodilators, we can use short-acting beta agonists and we can use short-acting anticholinergic agents. So the combination of short-acting beta agonists with short-acting anticholinergics is commonly used or it is recommended. So the benefit of combining these two drugs is seen in patients with stable COPD. So this is not studied for patients with COPD exacerbation, but the study is for stable COPD and it is useful in studies in stable COPD. So this is extrapolated from the stable COPD and it can be used for acute exacerbation also. So we can use short-acting beta agonist or we can use a combination of short-acting beta agonist with short-acting anticholinergics. And the way of giving the drugs, as we have discussed, if the patient can take the drugs, we can use the metered dose inhaler. If the patient cannot tolerate or cannot take, we can use the nebulizer as a way of giving the drug. And the use of other long-acting agents, if the patient was initially taking these long-acting agents, the patient should continue the drugs when the patient can take or when the patient is able to take their long-acting agents. And systemic glucocorticoid, we have also discussed in asthma. They should be considered in all patients with acute exacerbation of COPD also. In the route of administration, the same, we can use IV or oral way of administration. And the other is inhaled corticosteroids may be considered in this patient, especially in patients with COPD exacerbation. The use of inhaled corticosteroids like budesonide or Pulmicort can be considered. That is, some of the studies suggest it is non-inferior to the use of systemic glucocorticoid. But still it is not strong evidence-based. But if you don't want to give the patient, if you don't want to give a steroid, or if you want to give the steroid sparing approach, we can consider giving inhalational corticosteroid with Pulmicort or inhalational budesonide. The other is we can use prednisolone, PO, or if the patient cannot take PO, we can use IV drugs. Regarding the antibiotics, infections are more common or more related with exacerbation in these patients. So we should more commonly use antibiotics in patients with COPD exacerbation. So to give antibiotics, we can consider some criteria. Those patients with all three cardinal symptoms: worsening of shortness of breath, worsening of cough, worsening of sputum production or purulence of sputum. So presence of these three symptoms is one of the indication. Or the other is if the patient is having sputum purulence with other one of other cardinal symptom, or if the patients are critically ill, or if the patients are hospitalized or on mechanical ventilator, that is also another indication. Other indications also recommended without strong evidence are like presence of comorbidity, frequent exacerbation, older age, having advanced COPD are also another indications for consideration of empiric antibiotics in patients with COPD. So when we consider empiric antibiotics, we should consider the local bacterial resistance pattern. So the common bacteria identified in COPD exacerbation are Haemophilus influenza is the commonest one. The others are Moraxilla, Streptococcus pneumoniae, and the Pseudomonas are commonly identified. So we can consider the local resistance pattern, and we should consider antibiotics for patients with this indication. Regarding the respiratory support in these patients, we should give respiratory support to maintain their saturation from 88 to 92%. And we should avoid excessive oxygen administration in these patients. Usually giving excessive oxygen may lead to vasodilation, pulmonary vasodilation, and may lead to hypercapnia in this patient. So we should avoid giving much oxygen. So we should give oxygen with a target of oxygen saturation 88 to 92%. So the way to give oxygen is using the intranasal, using the face mask, or using the venturi mask based on the patient's requirement. And the ventilatory support, if the patient is failing with other supportive treatment, or if the patient is requiring more respiratory support, we can consider other ventilatory support. Regarding the high flow nasal cannula, it is not well studied for COPD as well as for asthma patients. It is not well studied, but in the case of COPD exacerbation, non-invasive ventilation is well studied, and it should be strongly considered for patients with hypercapnic respiratory failure. So the indications to consider non-invasive are those patients having respiratory acidosis with high PCO2 or with low or decreasing pH, or those patients having persistent hypoxemia, patients with severe dyspnea, with substantial respiratory distress or change in mentation. They should have non-invasive positive pressure ventilation. Specifically, BiPAP should be considered. So we can use the BiPAP machine, or we can select the BiPAP option on the mechanical ventilator, and we can put these patients on non-invasive ventilation. So initial setting, we can start with the inspiratory pressure of around 8, and based on the requirement or based on the response, we can increase the inspiratory pressure, and the expiratory pressure we can maintain 3 to 5 based on the patient's response. And after putting the patient on non-invasive ventilation, we should follow the tidal volume, we should follow the minute ventilation to see the response, and we should follow the oxygen saturation of the patient. And we should do arterial blood gas analysis after 2 hours of the patient on the non-invasive positive pressure ventilation. So if the patient has no significant improvement on arterial blood gas analysis, or if the hypercapnia is worsening, we should consider putting the patient on invasive ventilation or mechanical ventilator. So for mechanical ventilator, there are some indications. So if the patient is not tolerating non-invasive, or if the non-invasive is not adequate for the patient, or if it is failed, or if the patient is having life-threatening hypoxemia or hemodynamic instability, impaired airway protection, in that condition, we should consider invasive mechanical ventilation. So invasive mechanical ventilation, most of the settings as well as the complications are related to that of the asthma setting. But usually when we see, in general, patients with COPD, the ventilation with the mechanical ventilator is more easier than that of the asthma, because in COPD patients, the major problem is diaphragmatic fatigue. But in the case of asthma patients, they have the major problem is bronchospasm. So when you ventilate the patient with bronchospasm, it is not easy to control the bronchospasm with the mechanical ventilator. Even intubation can worsen the bronchospasm. But in the case of COPD, after intubation, the diaphragmatic fatigue, the diaphragm will get rest, and we can additionally manage the bronchospasm with the bronchodilators, so that in general, ventilating the COPD patients is much easier than that of ventilating patients with asthma exacerbation. Additional treatments, we should consider managing the comorbidities. COPD patients, most of the time they have other comorbidities like cardiovascular and others. So that should be addressed. And the VT prophylaxis, in the supplementation of vitamin D. So vitamin D has immunomodulatory effect, and it is associated with COPD exacerbation, or associated with decreasing the episodes of COPD exacerbation. So if the patient is having low vitamin D, we should consider supplementing vitamin D for this patient. We should always check the fluid status of the patient, and we should hydrate the patient if necessary. So after treating, we should consider discharge. So for discharge, the symptoms, physical examination findings should be improved, and the ABG and other parameters should come to the baseline, and the SAVA requirement should be more than or not less than every 4 hours, and no significant active comorbidity. So during discharge, we should educate the patient properly how to use their medications, avoiding the triggers. We should update the immunization status of the patient, and we should consider the maintenance. We should check the maintenance therapy of the patient, and we should check their inhaler technique, and with a short appointment, we can consider discharge. So common pitfalls we see in patients or in treatment of patients with asthma and the COPD exacerbation. Commonly we see under or overuse of antibiotics. So usually overuse is seen in asthma patients. So in asthma, it is not routinely recommended. So we shouldn't use routinely. We should have a strong evidence of bacterial infection to consider antibiotics in asthma exacerbation. And the underutilization is usually in COPD patients. So we should assess the patients, which we should check for indications, and we should give antibiotics accordingly. And the other is underutilization of non-invasive positive pressure ventilation, usually in patients with COPD exacerbation. So this should be it should be utilized in patients with COPD exacerbation, because that can avoid the use of invasive mechanical ventilation and associated complications also. The other is what we commonly see is overburdening during the procedure of intubation. The patients with asthma or COPD exacerbation, that should be also should be avoided. So the bagging should be gentle in these patients, because these patients already having gas trapping, that overbagging will worsen the gas trapping and may cause pneumothorax. And the other is stopping or de-escalating treatment in pregnant. That is also not appropriate. We should improve that. Thank you very much.
Okay. Thank you very much, Dr. Ephrem. That was a very interesting and engaging presentation. So the strategies and the practices you've outlined for recognizing and managing the acute exacerbations are important for health providers to understand. So once again, thank you. So having said that, we'll directly proceed to the Q&A session. So after the Q&A session, we'll proceed with the post-CME quiz. So I'll shortly share my screen and we'll proceed with the Q&A. So the first question reads, can we consider bronchial asthma without wheeze?
So regarding bronchial asthma without wheeze, as I have mentioned, usually the patients with bronchial asthma come with worsening of symptoms and changing their baseline pulmonary function test. But in some patients, they will have significant change in their baseline lung function, but you may not see significant symptoms. You may not see symptoms that correlate with the change in lung function. So sometimes you can see patients with worsening of the symptoms, but the symptoms may not include the wheeze. You can see patients without wheeze also.
Okay, thank you. The second question reads, what is the effectiveness of 4 milligram salbutamol tablet for acute asthma exacerbation?
Okay, so in general, treating patients with asthma exacerbation, the use of PO bronchodilators is considered to be non-effective. So they are not recommended for use as PO. So we can use the bronchodilators inhalational, as we have mentioned. Otherwise, using the PO bronchodilators is not effective.
Thank you. The third question reads, is IV hydrocortisone as effective as oral prednisolone?
Yes, they are effective, but we should use the comparable dose. So we should use the dose of prednisolone 40 to 60 milligram. So the amount of hydrocortisone we give IV should be equal to that of the prednisolone. So you can use the IV, you can use the PO, their effect is similar. So you can use one of the two based on the whether the patient can take PO or not. So if the patient can take PO, you can use prednisolone. If the patient cannot take PO, you can use IV hydrocortisone.
Thank you. So the fourth question reads, if other options are available, is epinephrine IM or IV use justified? If so, at what dose?
As I have mentioned, there are non-standard therapies. So the non-standard therapies include the methylxanthines, the non-treatment without benefit. So that includes the methylxanthines and others like so specifically when you see the epinephrine and other anesthetic agents, they are not strongly evidence-based. But in the absence of other options, after treating all the possible, after using all the possible options, or after exhausting all the possible options, you can consider epinephrine is one of the non-standard therapies which can be considered. So these non-standard therapies include using the anesthetic agent like ketamine, using these parenteral drugs, parenteral bronchodilators, including the epinephrine and the terbutaline, are the options we can use in the absence of other options. So you can use this drug, but it is not strongly evidence-based, but you can consider in the absence of other options.
Thank you. The fifth question
is, the other is regarding the use of epinephrine. What we should know is, specifically asthma associated with anaphylaxis, it can be used as a first line also. It can be used if the asthma is specifically associated with anaphylaxis.
Thank you. The fifth question reads, how do we administer magnesium sulfate and how do we dilute it with normal saline?
Okay, so you make the 2 grams of magnesium sulfate and you make it 20 ml. You mix with normal saline and dilute it to make 20 ml. So you give that over 20 minutes, and the dose or the amount you give is, you give single dose mixing with normal saline. So the recommended is only 1 dose or single dose of magnesium sulfate.
Okay, thank you. The sixth question reads, what is the place of magnesium sulfate in acute asthma, in acute exacerbation of asthma, and how often should it be given per dose and per day?
I think I have answered this question. Magnesium sulfate recommended is only 1 dose, and it should be also after giving the initial treatment. If the initial 1 hour treatment is not effective, if the patient has no significant improvement with the initial 1 hour treatment, magnesium sulfate only single dose is considered. So no frequency to consider. You give only single dose of magnesium sulfate. No need to repeat.
Okay, so the seventh question is regarding the challenge in our setup. So the challenge in developing countries is non-adherence and financial limitation to buy inhalational steroids, which are the backbones of asthma control. So is there a way to tackle this problem?
Okay, currently in our country, commonly what we use is a combination of inhalational corticosteroids, that is budesonide with formoterol, that is Symbicort. So the cost is very high if you check in the private pharmacies. But I think currently it is available in Kanama pharmacies, and it is for free for patients with health insurance. But for others, it is not free. But the problem is, as you mentioned, in developing countries, it is a major problem. But I think in the future, they will expand the drugs like Symbicort. So those patients having health insurance, they can use the drug from the Kanama. I think it is for free in the Kanama pharmacies.
Okay, thank you. The eighth question reads, what is the role of aminophylline in asthma management, especially in setups where other medications are unavailable?
Yeah, as I have mentioned, those treatments without any benefit. One of those treatments is methylxanthine or aminophylline. So previously it is commonly used, but when you see the effect of aminophylline, it is not much better than that of the other short-acting beta agonists. So if you are using short-acting beta agonists, it is no benefit to add other drugs like aminophylline. Rather, you are increasing the risk of the side effect of the drug. So rather than using the aminophylline, we can consider those non-standard therapies like using anesthetic agents and others if available. But aminophylline is not recommended currently for treatment in asthma as well as in COPD exacerbation.
Okay, thank you. The ninth question reads, what is the glucocorticoid of choice during pregnancy and what's its dose?
Okay, glucocorticoid, you can use any of the steroids available. You can use prednisolone, hydrocortisone, even methylprednisolone. But some of the papers or guidelines recommend prednisone rather than prednisolone. So if available, you can use prednisone. But in the absence of that, you can use prednisolone as well as other steroids.
Okay, thank you. So the 10th question reads, how do you see the use of Symbicort for acute exacerbation in regards to single maintenance and reliever therapy or smart portion?
Okay, the use of Symbicort for acute exacerbation. For acute exacerbation, for mild exacerbation, it can be considered, but in acute exacerbation, if the patient is having severe or life-threatening exacerbation, we should use inhalational albuterol and other short-acting anticholinergic agents. On top of that, if the patient was initially taking that drug or Symbicort, when the patient is able to take, you can start that drug whenever the patient is able to take. Otherwise, in severe and in life-threatening exacerbation, it cannot be used as a sole drug for treatment.
Thank you. The 11th question reads, why is peak flow meter not available in most of our healthcare settings? So is this particularly associated with cost?
Really, I don't know the cost, but I think the cost is not much, even rather than the peak flow meter, even the spirometry is not much costly. So I think that can be easily available everywhere. I think in Addis, many hospitals having this peak flow meter, but it is not functional most of the time. It is not being used. The problem is, I think, because of the awareness, the technique is not much difficult to use that, and it can be easily used. And the cost is, I think it is not much, but I'm not sure the exact amount, the exact cost of big flow meter.
Yeah, thank you. The 12th question reads, what is the definition of status asthmaticus?
Okay. Status asthmaticus means patients having severe life-threatening asthma who are not responding for your treatment. So that is type of asthma. So it is severe type of asthma exacerbation, which is not responding to the standard therapy.
Okay, thank you. The 13th question reads, is there a cutoff pH level for intubating life-threatening asthma exacerbations?
Okay, so there is no specific or cut point value for patients with asthma exacerbation. So we should correlate the ABG findings if you do ABG, and we should correlate with the clinical parameters of the patients or the respiratory condition of the patient, the respiratory rate, if it is decreasing, if the effort is decreasing, if on the ABG, if the level of the carbon dioxide is increasing, and if the pH is decreasing, that is an indication. But there is no specific value to consider intubation.
Thank you. The 14th question reads, how do you see the use of inhaled corticosteroid and long-acting beta agonists like Symbicort for acute exacerbation of COPD?
Okay, so this Symbicort can be used as reliever. So that is not possible in patients with severe or life-threatening exacerbations. But in mild cases, we can consider. But in severe life-threatening exacerbations, we should consider nebulized or metered dose albuterol or the combination of albuterol with SAMA rather than the Symbicort. But after starting those short-acting agents, you can consider continuing this drug or the Symbicort if the patient was initially taking.
Thank you. The 15th question reads, how about mucolytic agents in COPD patients?
Okay, so one of the treatments without any benefit is the use of those mucolytic agents is mentioned as one of treatments without any benefit. So use of mucolytics is not recommended as standard therapy during the acute exacerbation. So it is not recommended in acute exacerbation, or it is considered as treatment without any benefit.
Okay, thank you. The 16th question reads, what is your recommendation on spacer lengths when using meter dose inhalers?
Sorry, 15 or 16?
The 16th question reads, what is your recommendation on spacer lengths when using metered dose inhalers?
Okay, so the spacer is, it depends. So using the spacer in patients who are not able to take or patients with severe or life-threatening exacerbation. When you give with a spacer, you have two options. The spacer with a mask or the spacer without mask. So, and the use of that also depends the type of the patient, the cooperativeness of the patient, and the other is the length of the spacer. Honestly, I'm not sure the length of the spacer that should be recommended. Is there any recommendation? I'm not sure.
Okay, thank you. The 17th question reads, what is the relationship of vitamin D deficiency and COPD?
Yeah, so there are some studies which, as you know, vitamin D has immunomodulatory effect. So there are studies suggesting supplementing with vitamin D, especially those patients with severe vitamin D deficiency. Supplementing with vitamin D has decreased the episodes of exacerbation. So those patients with acute exacerbation should have their serum level of vitamin D, and they should be supplemented with vitamin D if they have a deficiency or severe deficiency.
Okay, thank you. The 18th question reads, what is the place of systemic SABA in the management of acute exacerbation of asthma?
Okay, that is, I think, a repetition. I have mentioned parenteral bronchodilators. I have discussed about the terbutaline and epinephrine, specifically terbutaline. So these are some of the treatments considered as non-standard therapies, but in the absence of other options, these are the drugs or the treatments which can be considered in the absence of other options. So the use of parenteral, generally they are known as parenteral bronchodilators, including the epinephrine and terbutaline. But we shouldn't use terbutaline with epinephrine together, but one of them can be considered in the absence of other options.
Okay, thank you. The 19th question reads, so there's a challenge with differentiating asthma and COPD in old age in a setting where we don't have spirometer. So what are some of the workups we can use to differentiate the two other than spirometer?
Okay, so in the absence of spirometer, it is difficult to say there is asthma, specifically for asthma diagnosis. But based on the clinical history of the patient, you can take the detailed history. So usually asthma starts in the early age, unless it is occupational asthma. Occupational asthma can start in the adult age or any age. So age of onset is important. The other is seasonal variation is another important factor. And you can ask for other risk factors, having family history, having other allergic history, or regarding the COPD, other risk factors like exposure to cigarette smoking or biomass exposure. These are important things to consider to diagnose in the absence of spirometry. So otherwise, without having a spirometry, unless you find imaging findings like lymphomatous change on the chest imaging, it is difficult to say this is COPD or this is asthma without having a pulmonary function test. But
Okay,
those
thank you.
studies may help to decide on the management of the patient.
Okay, thank you. The 20th question reads, would you recommend screening for vitamin D in the management of asthma and COPD?
Yes, in the case of COPD patients with COPD exacerbation, we should check their serum level of vitamin D. And if it is severely decreased, we should consider supplementing those patients.
Okay, thank you very much. These are all the questions that have been forwarded to the Q&A to the chat session. Okay, so the first question reads, 20-year-old boy came to the ED because of severe shortness of breath and dry cough for 30 minutes. His father was diagnosed with asthma as a child, and treatment with inhaled albuterol is initiated. A physician administers a second drug to increase the action of albuterol on bronchial smooth muscle cell receptors. So which one of the following drugs is most likely to have this effect? The first choice reads magnesium sulfate, B reads prednisolone, C is theophylline, and D is ipratropium bromide.
The patient is having asthma exacerbation, and for asthma exacerbation, the physician was started on short-acting beta agonist. So the question says likely, yeah, the second drug is going to be given, and the most likely this drug, the second drug, is most likely to enhance the effect of the albuterol. So from the mentioned drugs, magnesium sulfate is not to enhance the effect of the albuterol. The others, the combination of albuterol with ipratropium may help or may increase the effect, but specifically the systemic glucocorticoids, they decrease the inflammatory cells, and additionally they increase the expression of beta adrenergic receptors, so they increase the effect of the albuterol. So the answer is prednisolone, because the second drug is to increase the effect of the albuterol. So the correct answer is B.
Thank you. The second question reads, a 16-year-old boy is brought to the ED for worsening wheezing and shortness of breath over the past day. He has had asthma for the past 2 years, and he wasn't taking his medication for the past 1 week. Furthermore, he appears uncomfortable. His pulse is 120 beats per minute. Respiratory rate is 35 breaths per minute. There are moderate intercostal and subcostal retractions. Nebulized albuterol, ipratropium, and intravenous methylprednisolone were given. 1 hour later, he is lethargic, and magnesium sulfate is administered. His pulse is 150 beats per minute. Respiration are 14 breaths per minute. No wheezing is heard. Which one of the following is the most appropriate next step in the management? So A reads intubate with mechanical ventilation. B address epinephrine to nebulizer treatment. C is start non-invasive positive pressure ventilation. And D is provide an additional dose of magnesium sulfate.
Okay, so this patient has also asthma exacerbation, but he was given all the pharmacologic treatments, including the magnesium sulfate, and the patient has no significant improvement, and there is worsening of his respiratory condition. So initially his pulse rate was 35. Currently his pulse rate is around 14 per minute. So this patient requires immediate intervention rather than additional pharmacologic therapy. He needs ventilatory support. So for this patient, we shouldn't wait much. We should intubate this patient. He should be on invasive mechanical ventilator. So the answer is this one, the first one.
The third question reads, a 58-year-old man with COPD and hypertension comes to the ED because of shortness of breath 3 days after starting propranolol. His pulse is 64 beats per minute, respiratory rate is 20 breaths per minute. Auscultation of the lung shows diffuse expiratory wheezes. In addition to discontinuing the propranolol, which of the following drugs should be administered? So A is salmeterol, B is albuterol, C is prednisone, and D is tiotropium bromide.
Okay, so this patient has COPD initially, and the COPD was exacerbated after starting propranolol. So the first step will be discontinuing the exacerbating agent. So propranolol was discontinued, and after that, the first step or first pharmacologic management is the short-acting beta agonist for the acute exacerbation of COPD. So the patient should be on SABA or SABA and the SAMA combination. So from the options we have, albuterol is one of SABA, so we should start on albuterol.
Thank you. The last question reads, a 61-year-old man comes to you because of a two-day history of productive cough and worsening shortness of breath. He has had frequent episodes of a productive cough over the past 3 years. He had smoked 2 packs of cigarettes daily for 30 years, but quit 1 year ago. His oxygen saturation is 91%. Chest auscultation reveals diffuse wheezes and coarse crackles. Which of the following is the most appropriate initial pharmacotherapy? A reads prednisone and albuterol. B reads prednisone and salmeterol. C is prednisone and tiotropium. And D is albuterol and theophylline.
Okay, so this patient, when we consider the age of the patient and other clinical features, most likely this patient has acute exacerbation of COPD. So when we initially find the patient with COPD, when we start pharmacologic treatment, the first one is bronchodilator, short-acting bronchodilator, which is beta agonist. So albuterol is from the mentioned options, albuterol is our first choice. And the other is prednisolone. Another pharmacologic option is prednisolone, because after starting the bronchodilators, we should add corticosteroids, systemic corticosteroids for all patients with exacerbation. So prednisolone with albuterol should be started. So other options, prednisolone with salmeterol, because we need short-acting initially. So salmeterol is not indicated here. Tiotropium is also another long-acting anticholinergic agent, which is not recommended in initial therapy of acute exacerbation. Theophylline is also not recommended. So the answer is albuterol with prednisolone.
So once again, thank you very much. We are incredibly grateful for you taking the time to share your expertise and insight with us. Your knowledge and experience has been very invaluable. And thank you all for joining us today to hear from our distinguished guest speaker on the topic of management of acute asthma and COPD exacerbation. So once again, Dr. Ephrem, thank you very much. Thank you to all of our attendees who have joined us thus far. So thank you and good night.
Okay, thank you very much.